Hi, I'm Dr. Jonathan Weinsaft. I'm a cardiologist at Weill Cornell Medicine, where I direct the cardiac MRI program. It's a pleasure to be joining you all today, and I'm going to be speaking about imaging of Marfan patients, when and how. So as a background and as an outline for our talk today, we're going to be talking both about current approaches for risk stratification, as well as emerging approaches developed by our lab, as well as others, which really hold great promise in terms of yielding new insights that can guide clinical care for Marfan patients and patients with other aortic conditions. Obviously, we know that in terms of the worst complications of aortic disease, dissection and its sequelae strongly impact prognosis. If we look at patients with non-syndromic conditions, we know from IRAD and other registries that the presence of dissection in terms of non-syndromic aortic conditions is a very, very bad prognostic marker, and that the incidence of this is increasing and strongly impacts long-term prognosis. We also know that therapeutic options for both prevention and treatment of dissection and its complications are improving, which highlight the need for effective screening and risk stratification. What we've established in an array of studies, both in patients with Marfan syndrome, other genetic aortopathies, as well as non-syndromic aortic conditions, is that aortic size in and of itself is a strong prognostic predictor of outcomes. The larger the aorta, the worse the risk is for dissection, as well as whether it be type A or type B dissection, as well as sequelae of that. And so obviously we use aortic size, whether it be on ultrasound, CT, or MRI-based modalities to guide risk stratification and therapeutic decision-making regarding prophylactic aortic surgery for patients. One caveat, which is incredibly important, which we've shown in terms of our lab, is that methodology is extremely important, and that methodology in terms of measurement of aortic size can vary, even between highly experienced laboratories. To demonstrate this concept, we initially used data from the GenTAC cohort in which patients with genetically mediated aortopathies undergoing imaging, routine clinical imaging, and we quantified aortic size using two established methods. One being double oblique reformatting of the ascending thoracic aorta, the other being axial reformatting of the aorta. Now, these are widely utilized linear methods to assess aortic size. What we demonstrated in this initial proof of concept study is that aortic size strongly differed between axial and double oblique methods at all locations. Importantly, greatest differences were the sinotubular junction, an area in which size is widely used to impact therapeutic decision-making. And at all locations, oblique reformatting yielded smaller differences with size than did planimetry, than did axial measurements. So oblique agreed better with the reference standard of aortic planimetry. Importantly, with regard to surgical decision-making, standard axial measurements yielded a twofold higher prevalence of patients meeting surgical criteria for aortic graft surgery than it did oblique reformatting. And that was most strongly impacted in the ascending thoracic aorta. With regard to prognostic assessment, we've also looked at this issue in terms of both the strengths and limits of linear measurements. In an initial study, we looked at nearly 2,000 patients from the GenTAC cohort. These are all patients with genetically mediated thoracic aortic aneurysms, a quarter of whom had Marfan syndrome, over a third of whom had bicuspid aortic valve. And we looked at baseline imaging as well as standardized core lab analysis prior to clinical follow-up for dissection risk. What we demonstrated is that risk for dissection was 6-fold higher among patients with Marfan syndrome versus bicuspid aortic valve, 4.5% versus 0.7%, and that Marfan syndrome was associated with risk for dissection even after controlling for maximal aortic size. Here we look at prognostic utility of aortic size from that study, demonstrating that at the annulus and that in the ascending thoracic aorta, as well as in the descending thoracic aorta, size itself was greater among patients with subsequent aortic dissection versus those without. And that relationship varied based on history. Obviously, in patients without a history of aortic dissection, the prognostic value of size was greatest in the ascending thoracic aorta, whereas size was a strong predictor of recurrent dissection in the mid-descending thoracic aorta and thoracoabdominal aorta in patients who have had prior graft surgery. What's interesting is that despite the predictive value of aortic linear dimensions for predicting subsequent dissection risk, that prognostic strength was limited. Among patients with type A dissection, only 1 of 9 had a diameter above 5 centimeters, meaning a diameter meeting criteria for prophylactic surgical repair. And among patients with type B dissection, again, the large majority of patients who had events did not fulfill size-based criteria for intervention. What we're seeing is that patients with events have those events despite sizes that would warrant intervention. Here are some representative examples of pre and post dissection imaging in patients not meeting criteria for surgical intervention. Here we have a patient, as you can see on the left, prior ascending thoracic aortic graft, minimal dilation of the descending thoracic aorta, 3 centimeters, subsequent dissection on post dissection follow-up. So you can see a type B dissection identified here by the red arrows. Here's another patient on the right with minimal dilation of the aortic root, 3.1 centimeters in terms of its size, subsequent dissection despite not meeting criteria for intervention on that baseline imaging. What these data really highlight is the need for emerging approaches, better technologies to predict dissection risk and identify those people who have bad outcomes both before and after surgery. A number of groups have looked at this. I'm going to highlight data from Dr. Morris's lab, who's done outstanding work looking at aortic tortuosity, and then I'm going to touch base on some of the work that we're doing. Here in an initial proof of concept study, the Morris lab looked at 90 patients with connective tissue disorders, 2/3 of whom had Marfan syndrome, did a baseline MRA prior to follow-up, and analyzed exams for vertebral tortuosity, as you can see here, tortuousness, geometric distortion of the course of the branch vessels. What one can see is that vertebral tortuosity, an index of loading alterations on the aortic branch vessels, independently predicted subsequent events, even after controlling for diagnosis, as well as aortic size itself, highlighting this as a potentially novel marker of subsequent dissection risk. Other groups, including Parm Singh, who works with us, are looking at molecular imaging. So here's a hybrid PET CT looking at vascular inflammation, demonstrating vascular inflammation in a patient with Marfan syndrome in whom we can see increased FDG uptake in the aortic arc. In subsequent research, we've been particularly interested in looking at biomechanical forces on the aorta. Here's an initial proof of concept study in which we looked at 13 VAV patients and 10 controls, looking at distensibility. We compared those BAV patients as well as controls to patients with Marfan syndrome. And you can see the data for that on the bottom right. One can see differences in change in area between Marfan patients and controls, as shown on the bottom, with greater stiffness in the Marfan patients, and lesser distensibility. This is based on strain imaging for the descending aorta. In subsequent studies, we've looked at this concept in using echocardiography. In an initial study done by our group in which we looked at the predictive value of transesophageal echo, we examined 45 patients with thoracic ascending aneurysms undergoing ascending prosthetic graft implantation. We performed intraoperative transesophageal echo via routine clinical methods, and then we post-processed it for strain-based imaging, namely distensibility and distortion of the aortic wall, as shown here, pre-procedure and post-procedure. What we're doing is effectively edge tracking the distension of the wall during the cardiac cycle. What we can see in this cohort of patients who are undergoing ascending grafting is that biomechanical properties of the native descending aorta markedly altered following ascending graft implantation. Descending strain markedly increased, paralleling increases in distensibility. And importantly, patients with cystic medial necrosis had higher post-procedure strain than did those with atherosclerotic aneurysms or other conditions, demonstrating that the impact of grafting on biomechanical properties of the aorta may vary based on underlying disease etiology and diagnosis. In a subsequent study, we examined the predictive value of strain-based imaging among patients undergoing transthoracic echocardiography, both before and after prosthetic graft implantation. Again, this is routine image acquisition with post-processing using strain-based imaging to look at descending aortic distensibility following graft implantation. Here again, we can see that after grafting, with a mean follow-up of 6.4 plus or minus 7.5 months, native descending aortic distension increased, as assessed both by circumferential strain and change in fractional area. That increased distensibility in the native descending aorta, paralleled altered kinetics, as evidenced by decreased time to peak strain and increased flow velocity. When we looked further at whether this strain-based response varied based on aneurysm etiology, we demonstrated that magnitude of increase in strain, meaning magnitude of increase in biomechanical distension on the native descending thoracic aorta induced by that ascending aortic graft, was greater in patients with congenital or genetically mediated aneurysm versus degenerative aneurysms, paralleling larger descending aortic size and greater wall thickness and higher prevalence of calcific plaque in the descending group, in the degenerative group. We demonstrated as well that congenital or descending aortic aneurysms conferred a more than fourfold increment in magnitude of augmented descending strain after replacement of the ascending aorta. And that increase in strain was independent of both age as well as aortic size. So what we're really demonstrating is that potentially the ascending graft itself alters biomechanical loading forces on the native descending aorta, and that may provide a nidus for subsequently increase in wall stress, shear forces, and ultimately dissections in patients with congenitally mediated aneurysms. To investigate that further, other groups and our group, have similarly used techniques using MRI-based 4D flow assessment and biomechanical assessment of the aorta. In an initial study by Michael Markle's group, the group demonstrated that aortic flow physiology varied in relation to underlying aortic condition and differed between bicuspid patients and controls, as well as between patients with tricuspid valve and aneurysm. In a subsequent study, we've been using 4D flow as well as strain-based imaging to look at the impact of ascending grafting on the native descending thoracic aorta. And this is being done in close collaboration with our colleagues, both Drs. Gaudino and Dr. Girardi at Weill Cornell Medical College, as well as biomechanical engineering colleagues, Dr. Rodelli and Maria Chiara Palumbo from the Polytechnical Group in Milan, Italy. In initial work, we've looked at 16 patients with ascending thoracic aortic aneurysms undergoing prosthetic graft implantation, for whom 4D flow CMR was performed for wall shear stress, flow velocity, and jet angle, and Cine CMR was done for circumferential strain in corresponding aortic areas. Here's a representative example of data analysis in which we can see that 4D flow and strain-based imaging is being performed both before as well as after ascending aortic graft implantation. What we can see in terms of initial data is that both strain and wall shear stress on 4D flow correlated with one another before as well as after surgical graft implantation. And with respect to changes in the aorta, what our 4D flow data has shown thus far is that in the ascending aorta and aortic arch, as would be expected, grafts produce alterations in both wall shear stress, increases in wall shear stress, and wall shear stress angle in the ascending, namely grafted areas. That change in wall shear stress is also changed by changes in biomechanical properties. What we're doing is putting in a prosthetic graft, which is more tensile and less distensible in terms of resistance to pulsatile forces of the left ventricle. And that change in native ascending grafting was corresponded by differences in wall shear stress, namely increases in wall shear stress, as well as increases in strain and distensibility in the native descending aorta. Again, feeding into this concept that grafting of the ascending aorta alters physiology of the descending aorta and may ultimately provide a nidus in some patients for subsequent dissection events. When we look more specifically in terms of disease etiology, we can see that changes in pre- and post-operative strain, as well as wall shear stress, vary based on underlying condition, and was greater among patients with genetically mediated aortopathies as compared to those with degenerative conditions, whether measured based on strain or wall shear stress-based methods as shown on this slide. So in conclusion, I think the data we know thus far is that current imaging approaches are predicated on size for aortic prognostic risk stratification of Marfan patients, as well as others with aortic aneurysm, thoracic aortic aneurysms. That new imaging technologies, whether it be molecular PET, biomechanical characterization by cardiac MRI, as well as hybrid imaging, hold the potential to yield new prognostic insights. And that emerging data suggests the concept that native descending aortic biomechanics, whether it be strain or wall shear stress, are altered after ascending aortic grafting, and that future research is warranted to establish the long-term prognostic impact of graft-induced strain alterations, as well as 4D flow alterations in native aortic physiology. Thank you again for your time.